What I'd like to do then, since I think some but not all of you know about the research group I'm involved in the inter-eye instruments, I thought it would be useful to give you a very brief overview of what these instruments are, and would propose they be added to your toolkit as yet another resource that you can look at to improve the lives of persons who've had hip fractures. And then I'd like to spend a bit more time looking at evidence that we have from different care sectors in terms of what the prevalence rates are of people who've got a hip fracture diagnosis in different care settings, the social demographic characteristics, their functional status, but also think about the issue of care planning, and hope to make the case for you there that we need to sort of recognize that individuals who have had a hip fracture are in fact a complex population with many things going on in addition to the hip fracture, and we need to address those other things in addition to the immediate injury if we want to see them be able to return home successfully. This is the family of instruments that I'll be talking about today. So we've developed assessment instruments for home care settings, for intake screening into home care, that's the contact assessment. We have instruments for use in complex continuum care and long-term care settings. We have a new instrument for the frail elderly in acute hospitals, including an emergency department screener, several mental health instruments, an instrument for adults with intellectual disabilities, palliative care, rehab instrument, a community health assessment instrument that we use with lighter care populations in the community, including in supportive housing settings, and a new family of subjective quality of life tools. This schematic shows the patterns of use of these instruments across Canada. If it's a solid icon like this up in the Yukon, that means that the government has either mandated the use of that instrument or strongly recommended the instrument be implemented. So what we see is that in terms of home care and long-term care settings, we really are closer than we've ever been to a national information system for those sectors. And most provinces that have been interested in one of these instruments are interested in multiple instruments. We've designed these instruments to function as an integrated health information system. So we're interested in addressing the needs of populations irrespective of where they are in the healthcare system. So people with hip fracture are not only in acute hospitals or only in home care or only in nursing homes, they're across the whole healthcare system. And so to address the needs of the population, you need to have an integrated health information system. So first of all, if we were to look at just the presence or absence of a hip fracture diagnosis in different care settings, what we see is that there's a fair bit of variety across different care settings. In long-term and long-stay home care clients, it's less than 5%. We see higher proportion of people that are ongoing clients in home care that have a hip fracture diagnosis compared to new admissions to home care. It's an important issue among ALC patients. So if we look at people that are ALC patients awaiting placement in long-term care, the hip fracture diagnosis rate is double, almost triple the rate that we see in the general long-stay home care client. And it is, there's a higher prevalence among those who are longer stay ALC patients who've been assessed more than once. In long-term care, the rates are sort of in between, at around 7%. Complex continuum care, we have a fairly high rate on new admissions, but not so much on people that stay in complex continuum care for 90 days or more. So each of the service settings has a slightly different profile in terms of prevalence rates for people with hip fracture. If we're to look at some of their social and demographic characteristics, now looking only at those who've got a hip fracture diagnosis in these different care settings, what we see is that the youngest hip fracture patients tend to be those in complex continuum care, and the oldest are those in long-term care settings by about a 3 to 4 year age differential. We also see the highest proportion of females with hip fractures in long-term care settings, with the lowest in complex continuum care, sort of following that age pattern as well. But then the other important contextual variable thing about is marital status. So for long-term care home residents with a hip fracture, only 20% are married compared to about a third of complex continuum care. So this is now that cognitive performance scale graph that I showed you earlier for everybody, but focusing specifically on people who have hip fractures in different parts of the healthcare system. And just so you can sort of see, this is a 2007 to 8 data cut the numbers that we have to work with in home care, about 5,700 people, ALC patients, about 1,600 of them, 1,900 in long-term care homes, and about 2,000 complex continuum care. So sample size isn't a problem. We've got census level coverage and everybody with a hip fracture diagnosis in that year. And what we see is that when it comes to cognition, they're quite different populations that are being served in the different care settings. Here are some examples of different protocols that would be triggered for different individuals in these different care settings. And so if we look at the falls cap, it's actually based on the occurrence of falls within the last 90 days. And we see that there's a fair bit of diversity in these settings. Certainly for every population, falls are an issue, but falls have been more likely to have occurred recently in the ALC population and the complex continuum care population, followed by home care, but they're more distal for the long-term care population. Only about 20% have fallen within the last 90 days. There was about 80% of the ALC patient population. So this might be another way of thinking about their proximity to the injury that led to them, the hip fracture. But there's also other dimensions to think about. So this looks at issues around behavior disturbance. So being abusive of others, being verbally abusive, physically abusive, socially inappropriate behavior. And we see substantial differences in hip fracture patients across the different service settings. If we look at pain, again, there's important differences. For all populations, the rates of pain, except in long-term care, are that the majority of hip fracture patients have moderate to severe pain. The blue are people that have very high levels of pain in different service settings. So in home care, those hip fracture patients, about 60% of them experience pain and about 15% have very severe pain. It's about 30% of long-term care home residents, but the pain in long-term care is complicated by cognitive impairment. It's very difficult to measure pain in persons with cognitive impairment. So this may be a function of cognition, but it may also be a function of time since the fracture occurred. So if we look at people with a hip fracture in different care settings and look at, did they get any occupational therapy, or did they have access to physical therapy, we see some interesting patterns. If we look at home care, and really across most settings, we see this tendency that people who are new to the setting will get more access to rehabilitation than people who've been there for a while. So if we look at new home care clients compared to those who've been on service for 6 months or more, they're somewhere 3 times more likely to get OT, about 4 times more likely to get physical therapy. If we look at new long-term care home residents, they're about 12% get OT or access to a physical therapist at admission, but it drops to 1% for OT and 7% follow-up in long-term care. Notice a huge difference compared to complex continuum care, where about 3/4 will get access to an OT or PT at admission, but then for people who've been on service for 90 days or longer, those rates drop to almost a half. But the difference between long-term care and complex continuum care is particularly striking in this context. So to close, it's obviously a complicated population. There's many things going on with folks with hip fracture. In addition to the injury, there's issues of depression, there's social factors to consider, there's other medical complexities associated with it, and they have complex functional needs as well. They also get care in different care settings. People with hip fracture are spread across the healthcare system, and each of the settings seems to be serving a somewhat distinct population. So we can't necessarily generalize knowledge from one setting to another. We can learn from what's happening in different settings, but we do need to take into account that there are different patterns of patients being served with hip fractures in these different care settings. And I think our evidence is reasonably strong that access to rehabilitation for hip fracture patients depends in many ways on the care setting that you happen to be in. And our hope is that we can find ways to collaborate with you folks to make use of these data to help inform the important decisions you're going to be making about access to these services. So thanks for your time and attention.